And my next talk is how to perform a successful DCR. Anyway, the DCR in the beginner days, even I love to do DCR. Many people don't. Out of 10 people, 1 people, I am the first person who love to do DCR, and people come to see my DCRs. I am never fed up with the DCR. So everybody knows as that there is a lacrimal duct obstruction is there. There is a triad of 3 complaints, like watering is there. You always, when only watering is there, then you have to do syringing, you have to see the punctum. When swelling is there, discharge is there, and rhoplase is positive, then it is 100% sure that NLD block is there, then you don't have to do any other investigation. Now, how to proceed in DCR cases? So rhoplase is very important. Once you just put a finger over the medial canthal ligament, you will see the discharge is there. That means patency is there. NLD is blocked, but the all canalicular apparatus is patent. So don't do unnecessarily syringing, because iatrogenically you are damaging the punctum, your canaliculi and other things. You are correcting the things, but still patient is having watering in most of the cases, because in when we were junior resident, they are just breaking the needle and doing them, because they all crenated margins. They cause erosion, abrasion in the canalicular area, and they cause further cause stricture. So syringing should be done only for academic interest, for beginners, to just 3/4 syringing just to know how it is done. Otherwise, it should not be done routinely. So as you know, all this pre-cycle and post-cycle, just to show that after syringing, a probe is passed and whether it is a canalicular block or common canalicular block. And the other assessment is very important. Hematological examination is very important, because DCR is a surgery in which there is a lot of bleeding. Normally bleeding is not there if you are in proper space and you proper evaluation and good instruments and good visualization is there. Bleeding is never a problem. But in case their oozing is there, there are a lot of medicine are there. You can give 10-exa medicines are given 2 tablets just before 1 hour before to the patient. Bleeding is lessens. Use adrenaline, or when there is a contraindication to adrenaline, then it is a problem in some cases where we have to otherwise use GA cases, or patients where are very very. So BT, CT, PT and all these investigations are very important. History of the patient, taking care of trauma. Trauma causes surgical landmarks more difficult to operate, and results are the success rate decreases. So all these things you have to pre-operatory you have to do the assessment. Now nasal examination is very important. Anterior nasal cavity we can see, but if there is a DNS or some growth is there, I have got a problem in one patient, because I am also freelancer. I gone to Patna, they didn't examine nasally, so I was in problem. First time in my 30-year practice, I basically aborted that case and sent immediately to the ENT surgeon, and he said there is a very big polyp is there. And the moment I opened the lamina papracia, suddenly bleeding stopped, and I had done all efforts. Bleeding was not at all stopping. So I packed it very immediately and sent immediately within minutes to the ENT surgeon. So ENT don't think that you are sending your patient to somebody else. If you are in doubt, always do endonasal examination and give pre-operative nasal decongestion at least 1 week, so that good sac flaps are made. Because a lot of people are having this URI problem, NLD block and many things. So this mucosa is not healthy in most of the cases. So decongested is very important. So the local anesthesia is given along with adrenaline. And the main problem why DCR fails, because the site of ostium is very important. When there is abnormal position, inadequate size, or abnormal direction is there, then we are lost somewhere. Sometimes you go more superiorly, sometimes you enter the maxillary sinus. So these are problems happens with the beginners, junior residents. So a senior person has to be there to dictate basically where the position is there. So now I will show the small DCR clip. So I normally press the anterior lacrimal crest with the spatula to mark the incision site, and exactly over this medial canthal ligament you dissect undermine the orbicularis, go directly to the lacrimal bone, and take care of the periosteum. Don't cut the periosteum. The things are retracted laterally along with the sac. Now I am retracting the periosteum. Now this is the area where lamina papracia is there. You just break and don't go inside. Go inside and lift it laterally, so that you should not injure the nasal mucosa. Start with a small punch, then shift to longer punch. You remove the whole lacrimal crest, one punch, and then see approximately your little finger should be able to insert into the this cavity, this ostium. Now retract the periosteum, because in case where there is no the sac flaps or the periosteum can be used, but also it also bleeds if you cut the periosteum along with other structures. Don't forget to inspect the area where there is a small bony fragment, so that you remove everything. Now here you see the tenting is actually exactly in the center of the ostium. That means your bone is cutting is absolutely in the center. You don't have to further cut the bones. In case you think the tenting is not in the center, then you again remove the this probe and cut again the remaining bone which is required. Now I normally remove the posterior flap. Anterior flap is fashioned very nicely, and you see reinforcement of the nasal packing is done just to blanch the nasal mucosa, so bleeding is less, and a good U-shape flap is made. And the posterior flaps are given relaxing incision. They should fall down, or you can suture in case you are doing double flap. Now suturing is done very meticulously, taking care not to take that nasal pack into the suture, otherwise next day when you remove, you will break the sutures. So 2 to 3 sutures are enough depending on the size of the flap. I normally put 2 sutures, but sometimes we may need 3 sutures, one in the center. When apposition is accurate, there is a good tenting, then there is no need to put this orbicularis suture and taking into this bite from the flap. But in case you think some doubt is there, you can take that bite, and always close the skin in 2 layers. Otherwise, it will give a depressed scar. So postoperatively, it is same, but the syringing is very important next day, just to wash away all clots or fragments, and if anything, and reassure the patient that we have done a good job. As my time is up, I will just highlight one case of this mucocele. Now, mucocele is have a different strategy to operate. Give very superficial incision, take care of the mucocele, dissect from all sides, and expose the mucocele. Then idea is you can't proceed with this mucocele. You have to deflate. Then give a proper incision, do a good suction, and make a good flaps, horizontal flaps of the mucocele. The only problem in this case challenging is it is long-standing mucocele. They are a very thin mucosa is there, so very difficult to suture. Sometimes cut through happens, and don't be cut short the flaps. So in case it is required, you can do double breasting, or you can exercise. If the good healthy flap is there, you can do exercise and then do the suturing, or you can double breast both flaps. So this is the trick in mucocele. So main complication is hemorrhage, which can be managed, I've already told. So what is the conclusion? A good block, either in sedation or GA, good nasal examination, blood evaluation, complete history, good hemostasis. Instruments are very important. Your punch should be very good, cut in one shot. Otherwise, it will, if you twist like this, it will you will break, or you will go somewhere else. A large ostium should be made, and it creates a mucosa lined drainage with primary intention closure with careful suturing of the flap. If sutures are not sutured properly, then you are in problem. And when you are passing the probe and it's not going properly, your probe is like this, and some bone fragment is there, and you saying your probe is not exactly in the center of the ostium, then you remove that bone also. Otherwise, first day only you will see that it is a failed DCR. So skin scar is not a problem. External DCR gives, I would say, it gives 99% in primary intention DCRs, and pre and post-operative decongestant are very important. Thank you, sir, for giving me time.
Thank you, Hardeep. I think that was a very good presentation on their external DCR. I think
my minimum time for DCR was 13 minutes with Dr. Maipal.
That's correct. The point I observed in his video is the denting. The denting of the lacrimal sac is very important. That he keeps as a guide. I know. I think some point he mentioned maybe long back. He make a nick on the sac and hit on the bone, and that he keeps as center and make an opening. Maybe that's our point he was telling about 10 years back. Maybe that you are
normally
not.
I don't do this MPL cutting, not required.
Yes, that's correct. That's one of the very good procedure as demonstrated, and moreover that in fact the thing is that you have to always get an opinion from the ENT. Now the trend is totally changing because the ENT opinions are very fond of doing endonasal DCR, and even now even oculoplastic, even I also started doing small little amount of endonasal DCR rather than going for external DCR because of we have some good colleagues of ENT people also.
Right.
But you just think in mind that always get an opinion from the ENT colleague, because in order to rule out your ENT causes for your NLD abstraction.